So we're beginning Unit 2, and I had one of your colleagues come in to office hours today and ask the question, which is a great question. How would you suggest I study for some of the Unit 1 material? Because I know the class is cumulative. And then I had somebody else come in and say, oh gosh, this class is cumulative. I said, yeah. So I have to like remember everything from this exam. Like, well, yeah. Life is cumulative, right? You can't, if you're going to be a physician, you're going to be a nurse, you want to be a PA or a scientist, you can't, you don't have a patient walk in and you tell them, well, I knew the answer to what you have in med school, but I graduated like top of my class. That was so few years ago. So we're going to have to start all over again. It doesn't work that way. You're going to have to remember this stuff. But we remember things that we memorize and we learn. Okay? So most of you in this class are too young to remember this, right? How many of you had a home phone growing up? Like on the wall? Oh, okay. Well, then maybe I understood. How many of you remember your phone number? Okay? From your childhood. Yeah, so me too. And I'm a little bit older than you guys. Okay? And that phone doesn't even exist anymore, right? Does your home phone still exist? Some of you? Some of you, yeah. Some of you, your parents are just like me. I still have a home phone. But it's not the one I grew up with. But I remember that phone number. How many remember the home phone of your best friend? Yeah, see? Look at that. How many remember the cell phone of your roommate today? Couple. like Siri, call Butthead, right? Yeah. And they just died with it. All right. So if you use the information on a regular basis, you will remember it. So the answer to the question of one of your colleagues is, I said, well, how about flashcards? How about make some note cards, and you can carry them around in your bag, and when you got some lull time, you're waiting for your Taco Bell, or wherever it is that you like to eat, you can pull out the flashcards and just look through them. And what would I put on there? I wouldn't make 550 flashcards from Unit 1. I would say, what are the top 5 or 6 topics that we talked about that are big impact topics? Okay? Obviously, inflammation should be at the top of the list. And write out maybe 5 note cards, 5 or 6 note cards for each of those main topics. And things like on inflammation. What are some examples? You tell me what you would put on your potential note card for inflammation. Neutrophils are the first responders. You could probably slap on there who are the second responders? Macrophages. That could be on one note card. Perfect. What's that? That's a cool tattoo. I would agree. I would totally agree. The M with the little sigma sign or whatever that little nomenclature is. What else? Innate immunity. Beautiful. Could you put some factoids about innate immunity? Yeah. Do you need to write out Hagman factor 12 and the cascade? I already tested you on that. You're like, thank goodness. Right? So you don't need to write that out. But the point is you're going to see some of this stuff foundational. I think another reason that Unit 1 tends to be more challenging is a lot of the Unit 1 stuff is foundational, meaning we're going to build off of that in Unit 2 and Unit 3. We're going to take inflammation all the way through, and all these little nuances that we learned about inflammation, now we're going to start using it, okay? And so I think it does get slightly easier in appearance because you have the basics, and now you can apply it. Question?
I was going to say, so you're probably not going to include Hagman factor in the coagulation cascade on the final because it's not like a foundational topic. Is that what you're saying?
I don't know. I'm sort of in love with it now, but I mean, I wouldn't necessarily go on record saying that there's anything that's hands off.
Okay.
But I mean, if I tested you on detail, I already tested you. I want to test you on recall of key topics. So I think, in fairness, that's a pretty detailed level. That if you need to go look up Hagman factor, now you guys could handle it immediately. You know it. Oh yeah. Now I know where we are. Right? That was the whole point. Okay. Is if there's ever a patient that presents with a coagulation issue, I mean, you guys will be well prepared to go look that up, and everything is at your fingertips now. And for you to navigate that cascade, you'll know how it all fits together, and you can figure that out pretty fast on having that information in front of you, right? So I'm not too worried about that. But the fact is, that now you'll never forget Hagen factor, right? Yeah. Anything else? Any other comments? So does that help? I mean, do you have to do note cards? Here's the other thing: is I was talking to another person in the office hours today. If you're not a note card person, don't become one magically. Like if it didn't work for you in the past, it may not work for you now. That's okay. It doesn't have to be note cards. You can just write it out in an outline format on a sheet of paper, two-sided sheet of paper, cut it up into like 3x5 segments, put them together, and put a rubber. Oh, that's a note card. So you don't have to do a note card, but my concept is there's nothing magical like, oh, well, I'm a colored pencil highlighter person, so great, go to town. I mean, whatever helps. Just if you don't use the phone number of your best friend that lived down the street, you would never have remembered it today, right? So some of these things, I'll get emails from former students that are now physicians, and they'll tell me, yeah, it's so funny, like I still talk about concepts that we learned at NAU, your path class, because they're using that information in their daily job. Okay, so if you use this stuff, you'll never forget. Okay, so stuff that you put on the shelf that you never, pick up anymore or never you have a use for, it just goes away and you're not going to store it. All right, that being said, let's talk about some useless information for a minute, okay? What do you call a bicycle with a pop tire? Bicycle with a pop tire. Popsicle. Very good. Well done. What's a vampire's favorite sport? Vampire's favorite sport. Basketball. Okay. What's a pirate's favorite reading to watch?
Arr.
Arr. Very good. Okay, that one was easy, huh? So, we're transitioning out into hypersensitivities. It wasn't a great way to break this up from Unit 1 to Unit 2, but I think this isn't bad. We've introduced some of these concepts, and now we're going to pick it up. We're going to talk about some detail on 4 different hypersensitivities. At the end of the lecture is a table chart that's not in your textbook. It comes from another textbook. It's like slide 28 or 29 or something like that. But it does a really nice job of summarizing. So hopefully we'll get that far today. If we don't, we'll finish up on Wednesday. Hypersensitivities. We're going to categorize them into 4 buckets, 4 different labels. 1, 2, 3, and 4. Depending upon the textbook, you might run into 5 classes of hypersensitivity. They might further subdivide it. So I want to already, immediately head off some of these questions for those of you that, are kind of bucket label people, right? Do you think that the immune system cares what category we put a hypersensitivity into? Many of you are shaking your heads, and you'd be correct. The answer is no, it doesn't care. We label these things because it's convenient for us to build test questions on, right? It's not even for you. It's for us so that we can categorize them, and then I can ask you about the 4 different classes, right? So just remember, there are going to be some overlap, and you're like, wow, that one's kind of, it could be a little bit of this and it could be a little bit of that. So there's definitely a spectrum, and there might be some bleed over into different categories. But usually we'll focus on labeling it as a hypersensitivity based upon some key principles, okay? And we'll talk about that. So the first 3, generally speaking, are antibody mediated, 1, 2, and 3. Antibodies are involved, and the driving force are antibodies. Type 4 involves T cells. Now, antibodies can be involved in type 4, but in type 4, there are definitely T cells that are involved. But you could have antibodies too. Do you see how that is already a little confusing? But the 1, 2, and 3 exclusively use antibodies. And then type 4 is sort of this blend. So let's talk about 1, 2, and first, and then we'll get into 3. But before we get there, let's talk about what is hypersensitivity. So hypersensitivity is a response that is beneficial, that is actually inflated. So it's an allergic response, which is an immune response, which is for your benefit, but now it's inflated or it's exaggerated. And so now it has this exaggerated response that leads to some tissue trauma and therefore tissue damage. So you're hypersensitive. Now being sensitized is important because you want a B cell to be sensitized. You want a B cell to respond. That's what that word means. But you want it to respond with an appropriate response. And this response of hypersensitivity is inappropriate. So we've all seen this, and we've used this word in our own relationships. All of you have experienced, like, a loved one, right, who is hypersensitive to some little button pushing that you do, right? And if you push those buttons, you realize that the response isn't justified to what the action was, right? It's just the same thing. It's a hypersensitive response, meaning that it's over and above what it's supposed to be. So it's inappropriately triggered and it's inappropriately maintained. That's what we said. Back to immunology, not your relationships. Okay? Put that on hold for now. So inappropriately triggered and inappropriately maintained. So an example is on this slide, which is hives. This is on our title slide or our beginning slide. These are hives. Hives are an example of a hypersensitivity that's inappropriately triggered and inappropriately maintained. It's difficult to control once it's started, meaning if you get an allergic reaction on your skin because you're allergic to something and you get hives, it just sort of runs its course. There's not much you can do. You can try to rinse off, right? Wash your hands. You pet a cat and you rub your eyes and you're allergic to cats. Oh gosh, right? But you can try all you can. You put eye drops in, but it just kind of needs to run its course. Okay? So once it's triggered, it's difficult to control. If the stimulus doesn't disappear, then we have what's called a positive feedback loop. You guys remember positive feedback? And so that response triggers the response to happen more aggressively. So when we get into this section, it's important for you guys to understand that hypersensitivity is just normal processes that are amplified. Normal processes that are amplified. And we've got basically these 4 categories, or there's 4 buckets, and we're going to characterize them on this slide. This is a great summary slide. And so you can see type 1 at the top, 2, 3, and 4. And you can start to appreciate what I characterize as antibody type 1, 2, 3, and then you've got domination of T cell in type 4. But remember, there can be antibodies involved in type 4. It's just because there are T cells, we typically characterize it as a type 4 response. So let's look at these one at a time. So if we look at type 1 IgE mediated, we talked about this in the last unit. I alluded to this. I alluded to an allergic response or an IgE mediated response being an allergy response. And this is very, very common in people that are atopic. Atopic is just a word that refers to an individual that tends to make more IgE than other people. So they're more likely to be in a category of having an allergy or having an allergic response. Atopic individuals, they produce more IgE than the median population. IgE does tend to be the lowest immunoglobulin in circulation if you look back to our prior slides in the last unit. However, in this particular case, it's upregulated, and so you see a very robust release. And this mediates allergic responses and responds to parasites. Type 2, tissue mediated or specific antibody mediated. So in this particular case, you get the production of IgG and IgM in a type 2. And so this is the root challenges associated with blood transfusions, or the rhesus factor that's found on red blood cells. So just to remind you back to 202, so we have a number of different blood types, right? We've got blood cells that express on their surface an antigen known as antigen A, so they're a type A blood. We have blood cells that express an antigen on their surface known as type B, so they're type B blood. We have red blood cells that express both antigens A and B on their surface, and so they're type AB. And then we have red blood cells that don't express any A or B, and they're type O. You guys remember this? We also have the rhesus factor. There's a number of different factors. The rhesus factor was first discovered in the rhesus monkey, and so you're either positive for it or you're negative for it. So if you're positive for it and you're type A, then you're A positive. If you're positive for it and you're type B, then you're B positive. If you're positive and you're type O, you're O positive. And if you do not have it, then you're O negative. You guys get the whole deal. So if you take a rhesus positive donor and you deliver it to a recipient who is rhesus negative, you're going to make IgG and IgM against that rhesus factor, and you will actually coagulate the blood. Okay? So, tissue-mediated or specific antibody-mediated type 2, you've got this antibody that finds tissue. Remember, we draw the antibody, and this is what configuration? What was that? Was it a monomer, a dimer, or a pentamer? It's the monomer, so that's what we always draw, right? It's monomer. And so the monomer is floating in the blood, and it finds the antigen and binds to the antigen, and that's the type 2. And let's do this for sake of clarity. We'll make our antigen red. Okay, so that's type 2. Type 3 is a little different, but it's somewhat similar. So type 3 is a complex. So now you get an antigen-antibody complex that forms, and that complex would be this situation together versus if this antigen was actually bound to tissue. So this antigen being bound to tissue or a cell, but in type 3, we've got our antigen and we've got our antibodies, and they form these complexes that actually bunch together, and when they bunch together, right, they can actually get trapped in different places, and we'll talk about where they end up. Okay, so we've got an antibody tissue-specific response where the antigen is on a cell or on a tissue. That's a type 2. And then we have this antibody-antigen complex where they find the antigen, but then they kind of agglutinate, and then that whole bundle gets trapped. And so in that complex, you see things like autoimmune diseases like systemic lupus, SLE. Type 4, this is T-cell mediated. You can have antibodies involved here as well, but the response is dominated by T-cells. And we call this a delay hypersensitivity. And some of the examples here are type 1 diabetes and transplant rejection. We'll get into some other examples as we go through the lecture, but these are just giving you some ideas of where we're headed. So type 1 diabetes, where you actually send out T cells to attack cytotoxic T cells, and they attack the beta islet cells in the pancreas and destroy them. Or in transplant rejection, you get both antibodies that circulate, and you get cytotoxic T lymphocytes that circulate, and you have a humoral as well as a cytotoxic T cell response targeting the donor tissue, like if you donate a kidney from one patient to another. Okay? All right, so that's where we're headed. That's our roadmap. And so now let's begin with type 1, and let's look at allergies. All right, most of us have an allergy to something. Okay? Most of us have an allergy to something. And in this particular case, some of these allergies can actually be fatal. They can be very dangerous. IgE mediated, they respond to these allergens, And the concept is you get sensitization that takes place because of the exposure of the antigen right up top. So we've got this B cell sees this antigen. You've got a T helper cell. This is a subset of a helper T cell or a CD4 positive T cell. And this B cell becomes sensitized and starts releasing more of the IgE. And as the IgE finds and binds the allergen, you get a second exposure that we'll talk about here in a second, and you start to degranulate and dump all of these chemical signals. And when you dump all those chemical signals, most of which are histamine, you cause a lot of vasoactive responses. So the histamine dump that takes place causes vasodilation of the vessel. It causes the vasculature to be leaky, right? It triggers the inflammatory cascade where you're recruiting neutrophils and macrophages into the area. And that's why in an allergy response, the tissue gets red, right? It gets inflamed, it gets puffy, right? Your eyes start watering because you are responding to this histamine dump. It's one of the reasons that the antihistamine as an allergy pill is very effective. Does it do anything to block the binding of the allergen? No, it just prevents the histamine from being dumped out. So in this type 1 response, we've got what we call mast cell sensitization. So the mast cell is sensitized to the allergen and starts dumping out histamine. That's the normal response. But the problem is, on the second response that we'll get to here in a second, the aggressiveness of which the mast cell dumps histamine is orders of magnitude larger than the first exposure. And that's what leads to a lot of these problems. So we've got vasoactive amines that get dumped out, which has immediate hypersensitivity. And then we've got our late phase reaction, which is like 2 to 8 hours later, that's because of our sensitization and our second response to that same allergen. So on our second exposure, you're going to start to see some things on this slide that sound familiar or should be familiar. So you can see on the second exposure, the allergen now binds to IgEs. So one allergen, 2 IgEs kind of co-localized to that location on the membrane. That causes a more aggressive degranulation and an immediate response where you're dumping histamine and you're dumping proteases and chemotactic factors. And it also triggers the nucleus to start generating more secondarily from scratch what we call de novo synthesis. So this de novo synthesis is referring to this arachidonic acid pathway that triggers the production of prostaglandins and leukotrienes. And if you guys remember back to Unit 1, prostaglandins and leukotrienes have similar activity as histamine. They cause vasodilation, a leaky vasculature, and they trigger the inflammatory pathway to occur. So in a second exposure to the same allergen, you don't get just histamine dumping out, you start triggering de novo synthesis, that's this term right here. This means production from scratch, or from the beginning. And that's referring to the utilization of phospholipid bilayers to form a intermediate as arachidonic acid that further breaks down into your vasoactive responders. And those are the leukotrienes and the prostaglandins that we learned about in the last unit. So it would be fair game for me to ask a question still on the utilization of arachidonic acid because it fits into the second response or second exposure for the de novo synthesis of how IgE-mediated hypersensitivity promotes aggressive vasodilation, leaky vasculature, and a lot of the problems associated with an allergic reaction. Make sense? So, what does this look like? What do these symptoms include? Well, I bet you guys could fill out this slide without even taking this class. When you have an allergic reaction, what happens? Right? We've got bronchospasm that can take place, laryngospasm. We've got edema, that's the collection of fluid and tissue. We've got rhinitis, that's the runny nose. We have red eyes or conjunctivitis. We have itching, an itchy skin response. Sometimes such to the point where the patient will itch so much that they start to bleed in that location, right? You guys have you ever itched a mosquito bite? It's just like so aggressive and now it's bleeding. You're like, how in that world did I, just itch that so much?
What causes that?
What's that?
What causes the itching?
What causes the itching?
Yeah.
It's that the allergen itself is causing a trigger to your, well, it's not substance P that stimulates pain, but it's a very similar pathway that stimulates nerve discomfort that is interpreted by the brain as being an itching response. So it's not necessarily a pain response, but the nerve is saying something's not quite right here. And so a lot of the reaction that's taking place in that tissue of the swelling is putting pressure on those nerves, and it's causing those nerves to tingle, and that's what gives you that sensation of an itch.
So it's the swelling.
So these vasoactive amines cause that whole litany: bronchospasm, laryngospasm, rhinitis or runny nose, itching. The terminology for itching is pruritus, Pruritis. You get cellular infiltration from that inflammatory response. It leads to tissue damage. And then the mucous membranes start hypersecreting. And the reason for the hypersecretion from the mucous membranes is interleukin 13 that's being triggered by this IgE response. So interleukin 13 that comes from mast cells is causing overproduction of mucus. And that's one of the reasons that the eyes are watery, the nose is kind of running. So if we look clinically at some examples of very aggressive types of type 1 hypersensitivity, we see things like anaphylactic shock, people that are allergic to foods. How many of you have a food allergy? And it could be relatively dangerous. Environmental allergy, like it's pollen, right, in the springtime, or here, it's some people are allergic to the ponderosa pine pollen, right? Have you guys seen that? There's certain times of the year where your car is just covered with this yellow dust. And some people here are actually allergic to that. Wasp or bee venom, certain drugs like penicillin. So this picture here that you're looking at is a view of the larynx. And obviously it's down the throat, a view of the larynx. So normal larynx is up top. The normal larynx is up top. This is a patient down low that is responding to a penicillin allergy. And so this is the laryngeal spasm that's taking place. And you can kind of appreciate a couple of things. Let me turn off the back lights. No, not the fan. Sorry. There we go. What I want you guys to be able to see from these images is you can appreciate the vasculature just on the other side of the laryngeal folds, right? So this is down the windpipe right through here. So this is cartilage material, this white material. And you can kind of appreciate the relative size. Look at how swollen this is. Look at this tissue is super swollen. And that laryngeal opening down the trachea is compromised, more than halfway restricted. So this patient's going to be having a difficult time breathing and actually may suffocate. The other thing that I want you to see is look at the coloration of the tissue. What do you notice about the differences in the coloration of the tissue?
Much darker, more red.
More red? Why is it more red?
More blood from vasodilation.
Vasodilation, more blood flow. Tissue edema, swelling, right?
Maybe more mucus secretion too.
What's that?
Looks like more mucus secretion too.
More mucus secretion down low, for sure. Do you have the resolution of the individual vascular elements here, like the little squiggly red lines? Now you can't even tell there. They're all blown out, right? All right, so type 2. So we're shifting to type 2. Type 2 is going to be an antibody that finds an antigen in the body. It could be sitting on a cell, like in the case of the red blood cell, if it's a donor mismatch, or it could be sitting in tissue itself. So it's a tissue-specific antibody-antigen complex that forms, but it's in location, right? It's tethered. It's stuck on a cell, or it's stuck in tissue itself. And so you can see a couple of examples here. And again, the examples that we're using are just examples. They're not all inclusive. There are other examples in all of these categories, but I'm picking to highlight a few so that we kind of focus our activities. So here you can kind of appreciate, this is a patient that had streptococcal infection of the throat, or strep throat. So now you've got the strep bacteria that's circulating around the body. And that strep bacteria can find antibodies in different locations in the body, right? The body will develop antibodies against the strep. And there might be the opportunity post-strep infection for some of these anti-strep antibodies to find tissue that it recognizes in different parts of the body that's unrelated to the strep. But the production, because the antibody has been manufactured against the strep, and now it's circulating around, and it finds something that it binds to. Remember, this is hypersensitivity, so this is the immune system that's gone sideways. And so it's binding to something that it has affinity for that's not streptococcal. Does that make sense? And so in this situation, a couple of these situations that are shown here, this can actually get into the bloodstream, circulate around. These antibodies find antigens on the surface of the heart and form a fibrinous pericarditis. Or they find antigens within the myocardial tissue themselves, and they form what's called myocardial Ashkoff bodies. These myocardial Ashkoff bodies are quite interesting. We've known about them for a long time. They were discovered years ago, originally called Ashkoff-Geibel bodies, and they were kind of first characterized by Ludwig Ashkoff and Paul Geibel. And these were found in the hearts of individuals that were wrestling with rheumatic fever. And so rheumatic fever is an inflammatory disease that typically follows a streptococcal infection, like strep throat. Or another name for it is scarlet fever, right? So we're talking about a couple of 100 years ago, when now you get strep throat, right? You're like, oh, everyone that gets a sore throat always is like, oh, I think I got strep. Right? You know, sort of like white stuff in the back. Oh yeah, you got strep. And we're like self-diagnosing all the time, right? Well, it is true, strep throat a lot of times will cause that white caps to occur on the back of the tonsils if you have tonsils. But nowadays, strep throat isn't necessarily lethal. But hundreds of years ago, it was, before we actually had, commonly prescribed antibiotics that could treat that. And so if a patient survived strep throat, which was not a guarantee, a lot of times they would develop what was called scarlet fever or rheumatic fever, is an inflammatory disease that targeted the heart. Okay? And so that's how we've known about this. And what you're seeing in this histology, hematoxylin eosin stain section, this is of heart tissue. Okay? So obviously this is a patient that has passed away. Right? You don't usually get a biopsy of heart tissue unless the patient is post-mortem. So these are normal cardiac myocytes on the right and the left, and this is fibrotic scar that almost at first glance looks like it would be the result of a heart attack or a myocardial infarction. But it's not. This is due to rheumatic fever. Areas of inflammation where you've got these strep-specific antibodies finding an antigen on the heart, post-infection, months to years later, and they're causing an attack or a response against that tissue itself. Right? So the immune system is attacking your own tissue. Right? This is a hypersensitivity. It's not supposed to do this, but this is what results areas of inflammation that has scarring or connective tissue scarring on the heart. So in the type 2 response that we're talking about, let's talk about a couple of other examples, but first let's talk about what can happen. So the outcomes, how can we deal with it? Or how does the body deal with it? How does the body handle a type 2 hypersensitivity? Well, number one is it can go through a process of phagocytosis. So you get opsonization and phagocytosis, and when that takes place, you engulf, right, the cell that's actually displaying the antigen. Complement is clearly involved, as you remember, and now we've got phagocytosis of the cell that is expressing that particular antigen. Or, in the case of Ashkoff body formation, we can form an aggressive inflammatory response towards the myocardium and cause tissue injury. How does that take place, you ask? Well, if you remember, right, we've got our ability for complement and FC receptor-mediated inflammation to utilize recruitment pathways to get neutrophils in immediately, secondarily those macrophages. And you remember these reactive oxygen intermediates, the reactive oxygen intermediates that we talked about back in inflammation, we referred to those as the reactive oxygen species. Do you guys remember that? And so that was that capability of these neutrophils and these macrophages to leverage oxygen metabolites and create a free radical inside of the macrophage, and then that would actually destroy the bacteria. But in the case of the heart tissue, do we have any bacteria present? No. We had bacteria present when the patient had a strep infection, but those antibodies are circulating and left over. And now they respond to other antigens, like an antigen that's sitting on the myocardium. It's not supposed to do that, but it is self-reactive. It's a leaky system, right? So these self-reactive antibodies weren't screened, and now they're out in the periphery and they're binding. And when you recruit numerous neutrophils and macrophages to that area, and they're all capable of these oxygen intermediates, but they keep coming, and then those neutrophils and macrophages burst, what happens? Or lyse, now you get tissue trauma. You guys remember that? Okay. So, Ashkoff bodies and myocardium, type 2 hypersensitivity. We're going to talk about two other examples here in a second. First question.
I was wondering if this is the same thing with like rheumatoid arthritis, like the same thing with strep.
No, it's a little different. We're going to get there.
Okay.
We'll talk about RA at the end.
And also, how do prokaryotic antigens like mimic eukaryotic antigens? Like, I feel like they'd probably be so different. And why is this not more prevalent in other bacteria?
That's a good question. I don't know the answer to that, other than I think it probably is maybe more prevalent than we realize. These are just the ones that we are well aware of. That's probably my guess. Then so prokaryotic mimicking eukaryotic.
Yeah.
So I think a lot of these antigens that we're trying to battle, like if we're trying to battle a prokaryotic bacteria, we're a eukaryote that has a lot of prokaryotic beginnings.
Yeah.
And so a lot of those systems were conserved. And so it's probably relics from ages of evolution where prokaryotes and eukaryotes are different, but there's a lot of similarities that were passed over from one to another, right? I mean, you think about the history of the mitochondria, right? You guys remember back to cell biology and the history of the mitochondria. So it is a dual layer membrane organelle, meaning the organelle itself has kind of its outer membrane, and then there's an internal membrane as well. And so the thought process is that mitochondria used to be outside the cell at one point in time, and now it's an organelle. And so there's a lot of crossover and a lot of genetic history that we can trace back to the mitochondria's beginnings. And so that probably has a lot to do with why antibodies that bind to prokaryotes have some crossover to eukaryotic antigens. Okay, so let's look at two other examples that are type 2, okay? Both of these are type 2, but they're a little different than the Ashkoff bodies. Again, there's lots of examples, but we're going to cover just a handful of each, right? So, in this particular case, we've got antibody-mediated cellular dysfunction. The first one that I want to talk about is Myasthenia Gravis. That's listed up top. So in Myasthenia Gravis, so this is from the Greek, meaning muscle. In the Greek, the myasthenia is muscle, and the gravis is Latin, which is weakness. So this literally translates from the Greek and the Latin to muscle weakness, myasthenia gravis. And so what's happening here is the body produces antibodies against the acetylcholine receptor. And these antibodies bind on the motor end plate, and that's the lower right image there. And they prevent successful transmission of the action potential. And so effectively what you have is flaccid paralysis. Flaccid meaning unable to contract, but it's paralyzed. So it's paralyzed in a relaxed state, or a flaccid state. And so if you remember back to 201, we're going back quite a bit, but this is the end of the nerve, right? Or the nerve end button, or bouton. And these are vesicles that contain acetylcholine. And when the action potential comes down the nerve, it stimulates through calcium signaling that vesicle to fuse with the end of the membrane and dump its contents. And now you get an electrical signal that turns into a chemical signal to cross the synapse. And it's supposed to bind to these little green binding sites, which is the acetylcholine receptor that's on the muscle side. So this is the nerve, and this is the muscle. So this is the neuromuscular junction, if you guys remember that, the NMJ. And so what happens in myasthenia gravis is you manufacture an antibody that binds to that acetylcholine receptor. It has specificity for that acetylcholine receptor. It has nothing to do with a prokaryotic bacteria. This is what is the problem here? This is we call a leaky immune system, right? So you have B cells that came out of the bone marrow that are making self-reactive clones and manufacturing antibodies against your own tissue. Your acetylcholine receptor gets an antibody that binds to it, and it binds and it takes up the binding site. So when the signal from the brain, from the motor cortex, goes down to the muscle, and it tries to send acetylcholine out to the muscle to facilitate the action potential to continue on, and you get muscle contraction, the acetylcholine receptor is blocked by this antibody that's already sitting there. And now these patients have paralysis. They're unable to move. And this is the case of myasthenia gravis. This is a type 2 hypersensitivity. Okay? Does that make sense? There's a lot packed in there, but you guys understand this concept of why does this even exist? Like, how did this happen? Sounds horrible. How did it happen? Well, we make B cells in what tissue? Where they come from the bone marrow. And they go through central tolerance, right? So if they're screened, about 90% are screened and they're signaled for programmed cell death. And only 10% or so, 5 to 10%, actually come out in circulation and are affected because they're not self-reactive. But if you've got a leaky system, what that means is you've got a self-reactive B cell or a B cell that's making self-reactive antibodies, and it makes it out of central tolerance. Is there a peripheral tolerance mechanism for B cells? No, there's not. Only for T cells. Remember that? Only for T cells. And so now we have this situation that takes place. I got one more example to talk about, but I have a question.
Is this like Guillain-Barré syndrome?
A little different, but yeah. Similar, very similar. Okay, so let's look at antibody-mediated cellular dysfunction as it relates to Graves' disease. So what is Graves' disease? So this is completely different than myasthenia gravis. Graves' disease is a type of hyperthyroidism. So thyrotoxicosis, where the thyroid is overactive. It's overactive because now you have antibodies that don't block, like what we saw with the acetylcholine receptor. Here, they actually bind and stimulate. So you can see in the lower left, now you're making antibodies that don't block function. They bind and they trigger the thyroid to make thyroid hormone. And in Graves' disease, when you have a hyperactive thyroid, because of these thyroid stimulating hormone mimicking antibodies, right? That's a lot of technical words. These are called thyroid stimulating hormone mimicking antibodies because they're binding on the thyroid stimulating hormone receptor. The thyroid stimulating hormone comes down from what tissue? Where is it manufactured? It's made from the pituitary. Okay? So the hypothalamus makes the releasing hormone, the pituitary makes the stimulating hormone. Stimulating hormone goes on to the thyroid gland and causes it to manufacture T3 and T4. You guys remember that? We'll talk more about this, okay, when we get to thyroid diseases, and I'll point back to this particular slide. We'll see it again. But this is an example because it's relevant of a type 2 hypersensitivity. So Graves' disease patients have an overactive thyroid. What do you think symptoms of these patients are? Overactive thyroid.
Hair loss.
Okay, some hair loss. What else?
Weight loss.
What does the thyroid do? What do thyroid hormones regulate? Metabolism. So if it's overactive, weight loss, thank you.
Increased body temperature.
Increased heart rate, difficult sleeping, okay? Make sense? These are the ones, the Graves' disease, the ones that have kind of the bulging eyes. They call it hypothyroid eyes, okay? We'll get there later. I'm not gonna bring it up again, or I'm not gonna go into more detail now, because we're gonna talk about it in a little bit. Okay, let's move away from 1 and 2, let's talk about 3 and 4. So 3 and 4, let's see how we're doing. Okay, we're running, what we're doing. We'll finish up on that too. So type 3, I definitely want to talk about type 3 today, and we'll probably introduce 4 and then we'll hit the pause button. So type 3 is this complex that forms that kind of agglutinates. And this immune complex formation that takes place, you can kind of see my attempt here on the blue and black, drawing, is trying to show you what's happening up on that top graphic. And so these are just examples. There are definitely many different places where you get a type 3 hypersensitivity happening, but I just want to give you kind of a couple of examples, 3. But we form what we call these medium complexes. These medium complexes of a number of different antibody-antigen binding together that clump. And then they deposit in certain places, and they typically deposit in places where you get a lot of filtration or communication with the blood. So you can see that we've got blood vessel walls, which is an obvious place. And you can kind of see from this picture how that happens. Is you got the antigen-antibody complex forming in the bloodstream, and then it gets lodged as a complex in the wall of the blood vessel. You've got neutrophils readily available. They don't even have to leave. They're floating through, right? And you can have aggregation, and the neutrophil can have its ROS activity right here in the wall of the vessel and cause what we know as vasculitis. Well, we've got other examples I want to talk about, like the kidneys. And we'll see with the kidneys we get a glomerulonephritis, and we also have it with joints. Now remember, the kidneys are a huge filter, and joints actually filter blood in order to make synovial fluid, right? So you get a lot of fluid filtration that happens in your synovial joints as well. So we have a type of arthritis, not rheumatoid, but we're going to talk about reactive. So we've got clinical manifestations of glomerulonephritis, arthritis that's reactive, not rheumatoid type. So I want to make sure you write that down clearly on this slide because it says reactive, not RA, which usually means rheumatoid arthritis. But if you're not paying attention, you look back at your notes, you may say, well, is reactive arthritis not the same as RA? It's like the same abbreviation. Now, reactive arthritis is usually just referred to as reactive arthritis. Rheumatoid arthritis is a lot of times abbreviated RA. And then we've got vasculitis that we talked about. So in this situation, so to answer your question earlier, so rheumatoid is a type 4 and reactive is a type 3. Okay, so I don't want to wait too long before to let the cat out of the bag because we might run out of time today. So rheumatoid is a type 4, we're going to get there, and we'll see if we have enough time to characterize all of type 4 in the remaining minutes, but I think we will. So type 3, glomerulonephritis, arthritis, that's reactive type, and then vasculitis, where these complexes are getting stuck and they're getting lodged in those particular locations. So if we look at type 4, this was the last one on that list that we introduced in the beginning of the lecture that said there is a T-cell involvement. And so I don't want you to think that there's not the opportunity for antibodies to be present here, because that does happen in a lot of type 4 hypersensitivities. But there is definitely a cytotoxic T-cell or a T helper cell involvement that's uniquely different than just B-cell activity and inflammation-mediated pathways from 1, 2, and 3. So here we've got cell-mediated hypersensitivity. We've got CD8 or CD4. We've got the involvement of phagocytic cells, and we get significant tissue destruction, and it's often delayed. It's often delayed. And so you can see from this particular panel, the top and the bottom, let's walk through this. We've got delayed hypersensitivity, where we've got an antigen-presenting cell. So it could either be a what? It could be a macrophage, a dendritic cell, what else? Or a somatic cell could be presenting as well, but they're not classically an antigen-presenting cell. What's another example of an antigen-presenting cell? A B cell or a plasma cell, right? Okay. So you got an antigen-presenting cell that shows the antigen to a CD4 positive T cell. This is referred to as what kind of cell? Helper T cell, thank you. This helper T cell releases cytokines that recruits inflammatory mediators to the location. Then you can also have CD8 cells do the same thing. But in T cell mediated cytolysis, where the CD8 positive T cell has direct activity, it actually binds to the cell that's displaying the antigen and destroys it. Okay, so this is what's happening with type 4. So what are some examples of type 4? So in type 4 hypersensitivity, we've got, this is not an exhaustive list by any stretch of the imagination, but Crohn's disease, this is, and I'm going to give you one that's not even on here, celiac. So Crohn's disease, this is thought to be a type 4 hypersensitivity, and it's an autoimmune disorder that attacks the gastrointestinal lining, Crohn's disease. Typically, it's classified generically as an inflammatory bowel disease, okay, Crohn's disease. So we've got contact dermatitis. This is a skin reaction that's due to an allergic reaction to allergens on the skin where T cells are involved, like in the case of poison ivy and poison oak. Okay. Multiple sclerosis. This is an inflammatory disease, MS, that attacks the myelin sheath. So that's the sheath that wraps the neuron in myelinated neurons that allows for more rapid action potential. So if you have a myelinated neuron and you destroy the myelin around the neuron, what happens to the action potential? It goes up or goes down? Speed goes down, and the ability to propagate electrical impulses to control muscle contraction is diminished. Type 1 diabetes mellitus, we'll talk a little bit more about that later on. It used to be referred to as juvenile diabetes or child onset, but we're not seeing only children being affected with juvenile. The picture here is contact dermatitis, by the way. Okay, this is contact dermatitis of the skin. So that's not hives. Hives are a type what? 1, IgE mediated. Because T cells are involved in a type 4 contact dermatitis, you've got a very different process because you have T cell involvement. So with type 1 diabetes, the attack is happening on the beta islet cells of the pancreas, and you start releasing or having the ability to produce a diminished amount of insulin. Hashimoto's disease. Hashimoto's disease, this is when the T cells themselves attack the thyroid. So it's not thyroid stimulating hormone. The T cells are attacking the thyroid. So Hashimoto's isn't a hyper upswing of the thyroid. It's actually hyposecretion of the thyroid because you lose the thyroid. Hashimoto's disease. Then the last one that's not on your slide, but there's a little room to write there, is celiac. So celiac is one of the newer type 4 that's entering the playground now. So celiac disease is type 4 because of T cell involvement. And it's a condition that causes trauma or damage to the lining of the intestine, typically prevents it from absorbing nutrition and foods that are critical for staying healthy. And it's a reaction, a T cell mediated reaction to very commonly gluten, which is found in wheat, barley, and rye, and even in some oats. So celiac is not, contrary to a lot of popular opinion, it's not an allergy response of a type 1. It's actually a type 4 because you have T cells that are involved. And that's why it's so aggressive. Okay? Where a lot of people do have an allergy to gluten, they have a gluten intolerance or a gluten allergy, that is very different than celiac. You guys with me? Where you could be developing antibodies, IgE antibodies to gluten, but in celiac, you actually recruit and deploy T cells to destroy and target the tissue through cytolysis. Okay, so very different ballgame. Okay, we're going to hit the pause button here, and this is where we're going to pick it up on Wednesday. We're going to finish out with hypersensitivity and autoimmune diseases. We'll pick it up with transplant rejection. And then what I want you to look at, I know we have a couple minutes, but I'm not going to go all the way there, is I want you to look at this particular table. So we'll finish up on Wednesday. This is towards the end. We didn't get this far. But I just want you to take a look, because you see the columns, you got type 1 kind of over on the left, and then it goes all the way to type 4 on the far right column. Columns go up and down. And so this one nicely characterizes the different types of hypersensitivities that we're trying to cover. So take a look forward, and then there's another lecture where we're going to talk about acquired, right, versus primary immunodeficiencies. And don't forget, we've got a post quiz on Friday. Okay? You guys have a nice couple of days, and I'll see you on Monday.